Welcome everybody to our inaugural Capacity Research Unit kind of webinar. And before we get started, I want to first acknowledge with gratitude that we are located where we get to work and do our research and those kinds of things, situated today on the unceded and ancestral territory of the Musqueam, and offer gratitude for the stewardship for the land and the teaching that we take forward with us as in all of our work as we strive towards our learning and unlearning and reconciliation. And I am thrilled to welcome everyone. Thank you so much. And I offer you, if you would like to let us know where you are and acknowledge the territory in which you are working and playing and living today, please feel free to do so in the chat. So for those of you who don't know me, I think I know everybody, but I'm Vicki Bungie here at the School of Nursing and the director for the Capacity Research Unit. And it is my absolute pleasure to introduce Dr. Allie Slemon. Are you getting used to that yet, Allie?
No.
and to welcome you as Allie shares with us her incredible work that was done through her dissertation research. And I'll let Allie go into titles and all that kind of stuff. And also a huge congratulations to Allie, who will start her new appointment as an assistant professor at the University of Victoria School of Nursing in January. And so congratulations, Allie, on all of these things. And yes, so how this will, just one little housekeeping is Allie will roll into presentation, and then we'll have some time for questions and answers and just a nice discussion, and I will facilitate and I will try and manage chat. And I know people will put their hands up and all that kind of thing, and we'll have some opportunity to talk about the work as well. And then at 1 o'clock, I invite all of the graduate students to stay on with us, and we're going to do a little Q&A on preparing for your doctoral defense and all of the learning and that we've had over the past little while. So again, thank you, Allie, for being here, for being so open to share and be our first, and for all of you for being here. So yeah, sit back and enjoy a pretty powerful piece of, if I do say so myself, a pretty powerful piece of work. And I look forward to the discussion. So, and thank you.
Wonderful. Well, thank you so much to everybody for being here. I am just so delighted. This feels like a kind of walk through my and all of our graduate journeys, and just to see all these wonderful faces and names here. So I am just so grateful. So today I am sharing with you findings from the long doctoral dissertation road that ultimately led up to Nurses' Enactment of Equity Promoting Practices in the Emergency Department, a discourse analysis. And I'll just say that there were other methodologies, and this was not always called a discourse analysis, but here we are. And in the COVID era, things certainly shifted, and I am very grateful to have been able to do this work. And this is the most exciting part for me, is when the research is done and there are findings, and we can really have this amazing kind of generative conversation. And I will definitely try to leave time at the end for some conversation, because I hope that there will be questions and thoughts. And I know a lot of us in this Zoom room are doing various approaches of kind of equity and social justice research. So I really look forward to your thoughts and comments. So thank you, Vicki, for situating yourself, and those of you who are joining from Musqueam lands and territory. I have a lot of acknowledgement to share because this research was conducted across the unceded land of many Indigenous nations, including the many that you see here. And I also want to share that, as Vicki kind of indicated, I now live and work on the unceded traditional territory of the Lekwungen people. And the land that I am now living on the island, is traditionally kind of lived in and continues to be predominantly owned by the Songhees, the Esquimalt, and the Saanich peoples, as well as the Lekwungen peoples. So I've had many people to thank, and I appreciate all of you for joining in on the chat to share where you are coming from. So a little bit of background to why I ended up finding myself doing this research study was that, as I think we all know and are kind of familiar with in some of our own work, there are a great deal of inequities and stigma that are perpetuated across the healthcare system, and particularly in emergency department settings. We can see the emergency department as almost a semi-public space, which in many ways is kind of technically open to the public 24 hours a day and 365 days a year, but where there are a lot of inequities and injustices that jeopardize access to care in the emergency department. Yet we can see that nurses have great potential for equity promoting nursing care in the emergency department. And we can see that nurses have a mandate towards social justice and equity, which is across a lot of our guiding documents. We often articulate a sort of shared mission to take up justice and equity in our nursing work. And the type of nursing work that we do in emergency and across healthcare settings is very deeply, we often say, kind of patient-centered, in that we spend a lot of time at the quote-unquote bedside, very much embedded in interacting interpersonally with patients and families. And there's so much potential here for equity promoting practice. However, we know that unfortunately inequities are often perpetuated, and inequities and structural violence that we see in society are often reified in healthcare settings and emergency departments. So the questions then that I had of the literature were, what do nurses do to promote equity? And unfortunately, we have a lot of gaps in this area, and there's not a lot known, despite really extensive and much needed theorizing and some empirical work about social justice and equity in the nursing profession. We don't have a lot of information that guides us in terms of what nurses actually do in their day-to-day, everyday work to promote equity, particularly in emergency department settings. And therefore, we don't have a lot of information about what supports are available for nurses in promoting equity and what guidance might be currently helpful, and what supports, institutional structures and processes might be needed to further support nurses in actually doing this everyday work of promoting equity and remediating inequities in emergency department settings. So that led to this research project really investigating a lot of these central questions. What do nurses do to promote equity in the emergency department setting? And what institutional structures, supports, processes, and systems are currently available that help them do this work? And what are the gaps and what might be needed? So the research question then that we all developed collectively in the committee and that I ultimately used to guide my research was, how does discourse shape nurses' enactment of equity promoting practices in the institutional context of the emergency department? So to answer this question, I drew quite heavily on a kind of intersecting theoretical framework of Iris Marion Young and Foucault's capillary power. So what this looked like and how it played out in my inquiry was, first of all, taking up Iris Marion Young. Young has a very particular kind of conceptualization and framing of social justice and power that was extremely helpful in thinking through how we conceive of some of these questions around equity promoting practices, discourse, and power in the emergency department. So Young notes that we often think of social justice as a matter of distributive patterns. So how do resources ultimately get distributed among groups, and is that equitable or is that just? However, she encourages us to kind of look upward and look upstream from simply distributive patterns to look at institutional processes and how institutional processes intersect with power to create injustice, and therefore locates social justice and equity in how do we shape and reshape these institutional processes and structures away from perpetuating injustice and toward promoting equity and justice. So she says it's not enough to just look at distributive patterns. We cannot find true equity or justice in simply how resources are distributed. We have to look upward at institutional processes and structures, and that's where we will disrupt some of these injustices and look toward equity promoting practice. So this is a really helpful framework in thinking through how do we conceive of the emergency department as a healthcare space, and how do we see nurses' work and equity promoting practices within that work as potentially disrupting injustices within this space? And I'll return to that when we come to our key findings. So Young's theory kind of draws from and then very much intersects with Foucault's construction of capillary power. And so kind of similarly, he says that power is ultimately situated in the extremities of institutions. So while we can look upstream at the actual institutional processes and structures that intersect with power to create things like injustice, we can kind of find that power or instances or evidence of that power in the very extremities of institutions. And he says that's where it shows up, in the capillaries of institutions. And then we can trace where that power is showing up kind of back upstream to what processes and structures are constructing that. So this was, again, a really helpful framing in thinking through nurses' everyday work, which really does, if we look at it through a Foucauldian lens, nursing work happens at the extremities of institutions. There's so many institutional processes and structures that sort of filter down into what that nursing work day to day looks like. And so by looking at what nurses do every day in terms of promoting equity and responding to inequities, we can then look kind of upward and upstream at the discourses and the discursive power that is shaping nursing work at the extremities of institutions. So taken together, Jung and Foucault's theoretical framework was an extremely helpful kind of positioning for how I thought about power, and then how I thought about equity promoting practices as a practice and as something that happens every day, and that being something important and key to look at in the emergency department, and then to explore how that everyday work and how those everyday practices were situated in the kind of broader, much very complex kind of intersection of discourse, power, in the institution. So the methodological approach I then took up to look at some of these questions was a Foucauldian discourse analysis. So following, understandably, from the Foucauldian theoretical framework, but also really intersecting with how Jung thinks about looking upstream at institutional processes and structures, and how we kind of see power intersecting with those as a potential for disrupting injustice. So discourse analysis, particularly looked at through a Foucault lens, helps us look at these intersections of things that you see on the slide. So orients us to questions of language, and how the language that we use is infused with discourse in a way that allows us to kind of make visible the discourses that are operating within language. And so discourses are often described as sort of these invisible, almost forces that are shaping our everyday actions and our everyday life, but reflect something broader about our society and the way that we construct certain things. And so language allows us to, again, make visible some of those discourses and to see what discourses might be operating and which might be more marginalized or absent in particular language. Discourse analysis often takes up text, as indeed this study did, and we can think of talk or language as a form of text, and then again looks for where discourses are showing up. We can then also see how practices and actions are shaped by the discourses that are present in language and text, and ultimately how these are reflective of structures. All of this being undergirded by power. So Foucauldian discourse analysis orients us to discursive power and the intersections of discourse and power, and how those intersections taken together are showing up in our language, text, practices, and structures. So this is a really, I think, wonderful methodological approach, and really allows us to see things through kind of a unique lens that I think helps unpack a lot of what we might be kind of seeing in an institutional context and in everyday nursing work. So in taking up Foucauldian discourse analysis, this is what I actually did. So I looked at 2 large hospitals in urban centers in British Columbia, and you can see here that they both see a great deal of patient visits annually. So 85,000 in one and 150,000 or 157,000 at the other. So very high patient volume, busy emergency departments that really allowed us to look at some of these complex nursing practices that were happening in a very complex emergency department environment. And you can see that there were quite a few nursing staff, and this includes casual, and to be honest, these are sort of approximates. It can be very hard to count nursing staff, as I'm sure many of us can empathize with, but a huge number of nurses kind of ultimately broadly involved in patient care in these 2 research settings. The data sources that I collected were in 3 categories, and ultimately were all kind of taken individually and together to inform the key findings. So firstly, we collected institutional texts from both of the research sites. So this included a wide variety of hospital mission mandate value statements, policies, some guiding documents, and even some things like blank forms that were used in the emergency department. And many of these were collected in advance of any data collection through publicly available policies. And what I did for that was to scan essentially every available policy and look for those that spoke to or included discourses around, broadly speaking, issues of inequities and equity as it relates to nursing work. So that was a somewhat loose category. And so I, at first, was a bit over-inclusive, which was very helpful because ultimately then I continued to gather institutional texts through individual interviews, which I'll speak about in a minute. But as nurses, nurse leaders, and other healthcare providers mentioned institutional texts, I would continue to kind of build those into the data set to be able to have this sort of intersecting analysis ultimately of discourses as they operated across nursing text and the original institutional texts. So then secondly, I also gathered nursing professional texts at both the provincial and national levels. So discourse analysis often looks for texts that claim authority over something, over the topic that you're looking at. So I was looking for texts that really claimed authority over what nursing practice looks like or what nursing work looks like. So that, for example, included the CNA Code of Ethics and other nursing professional documents that kind of shaped how we think about and how we actually enact nursing care. And then lastly, I gathered what we call in this dissertation nurses talk. So that was through individual interviews, which because of COVID, were all conducted on Zoom and were across both research settings. And I looked at how nurses talk revealed a lot of the same, or kind of exposed or made visible some of the discourses that shaped their work, and in particular shaped their equity promoting practices and how those operated within the emergency department setting. In data analysis, I utilized ultimately Parker's guidance, and there's some variation in how specific and useful some of the guidance around discourse analysis is, and particularly the guidance that takes up a more kind of Foucauldian angle or allows for that sort of theoretical perspective to shine through. So Parker was very helpful in terms of providing some of that like logistical and kind of more theoretical guidance for data analysis. And really the aim here through using Parker and then through the lens of the theoretical frameworks was to distinguish and identify discursive power and how that was intersecting with nurses' equity promoting practices. So how discourse and power kind of variously intersected to shape and construct how nurses were able to enact equity promoting practice in this institutional context. So data sources ultimately were analyzed separately and together, and what we always call a quite iterative process, but because there was a lot of data, as you're about to see on the next slide, and many different types of data, there were moments where analyzing separately made some sense, and then moments where it really was a matter of analysis across different types of documents. And that was really guided just by what discourses were showing up and what discourses were absent, and how those discourses intersected with power, and then how that ultimately shaped equity promoting practices. So in the end, this is what our sample looked like. We had 33 healthcare providers, 26 of whom were nurses, and there were 12 leaders as well. So that included nursing leaders and then some other leaders. And we had intended originally to only conduct individual interviews with nurses. But in early interviews, it became very clear that how nurses were taking up equity promoting practices and how their everyday work was situated in the emergency department was understandably much more complex than just the nursing team alone. And so there were some really other kind of key roles that were showing up a lot in interviews, particularly social work and other kind of pieces of the broad emergency department puzzle, and different leaders who were really fundamentally shaping how this work was taken up in emergency department settings. And so we ultimately were able to include some of those other individuals and kind of roles in this project as well. And you can see some other kind of demographic information on this slide as well about that sample. And then in the end, the institutional and nursing professional texts taken together were a total of 31. So it ended up being quite a lot of pages of text. And we ended up with 26 institutional texts that included the policy, guidelines, documents, and forms that I mentioned. And that was winnowed down a little bit from the initial broad search, but was the institutional text that in the end spoke most to how discourses were operating in the emergency department and shaping nurses' work. And then 5 nursing professional texts, like I said, at provincial and national levels. So what we're all maybe really here for is the key findings. So a broad overview of what I'm going to be talking about today, and then I'll go into each of these kind of 3 broad findings. So firstly, the findings from this data showed that the discursive context of nursing practices and really illuminated how discourse and power intersected to construct what the emergency department was and how nursing work was situated within the nursing department or within the emergency department. Secondly, I'll speak to equity promoting practices as subversion, so how equity promoting practices were taken up and how they were discursively constructed in the emergency department setting. And then lastly, enduring power equity tensions in the emergency department institutional context. So firstly, the discursive context of the emergency department. So this was really framed through this notion of discursive power, which we've been talking about. So how discourse shows up, and what discourses are quite dominant in the emergency department and how those shape practice, and then what discourses may be absent in the emergency department and kind of what some of the impacts of those being more absent might be, and how those discourses are fundamentally shaped by power structures in the institutional context of the emergency department. So these discourses, you know, the study and the theoretical frameworks for theorize are not random, but are shaped by power. So firstly, discursive power fundamentally constructed what the emergency department is, or kind of what the main aim of the emergency department is and what the emergency department does. So one of the ways we see this is through this excellent quote, "The emergency department is for emergencies." So ultimately, the emergency department was constructed as a place that was for what was often called true emergencies. So traumas, injury, extreme illness, and that the emergency department was meant to quickly move people through so as to manage complexities of volume and flow. So the emergency department was seen as this kind of transitory space where people came in for a short period of time, but needed to leave quickly because there were always other people coming in through the door. And so then nurses in the emergency department and what nursing work was fundamentally constructed also through discursive power. Nurses' role was often to facilitate moving people along, to attend immediately to emergencies when they came along, and to then quickly, in many cases, and as much as possible, help facilitate discharges so as to allow for new people to come in the door. And for those of you who may have worked in emergency, this is so understandable, and there are real pressures that shape how emergency works. But then this methodology and this approach and looking at discursive power also helps us see how much that is also constructed by discourse and by power. As this is what nurses do here, is facilitate discharge, manage flow, allocate resources appropriately, including beds and nursing time and time of other healthcare providers, and then ultimately facilitate space for more people who are coming in. Discursive power also emphasized a distributive paradigm. So we can draw back to Jung and theories around kind of distribution of resources here, where nurses were ultimately responsible for distribution of resources and often equal distribution of resources through more of a equality kind of discourse and an equality paradigm. So this small quote really exemplifies that. They don't need to be taking up a hospital bed, right? And this notion of taking up really illuminates that discourse of the emergency department as a kind of complex construction of resources that need to be allocated appropriately among patients in an equal and kind of quote unquote appropriate way, and that nurses are sort of the stewards of this work. I don't know what that sound is. Sorry about that. So here we see how discourse kind of shapes how the emergency department is constructed through this data. So this individual says they, and they were speaking about people experiencing homelessness, will come in, especially on a rainy night, and they need IV antibiotics, they need wound care done, but they also end up in a bed. And then they get the care that they need, and then they don't want to go. And then you're ending up trying to persuade them or calling security. And I mean, that hurts the relationship, but the reality is we're there for emergencies. And once things are done, we need to move people along. So here we can really see how discursive power constructs nurses' work in terms of being there for emergencies, in terms of not being there predominantly for the relationship. That was a discourse that was more notably kind of absent in how the emergency department was constructed. And you can see the discourse of resource allocation here in this quote as well, that somebody ends up in a bed and then the nursing role shifts to ensuring that that bed will become free, ultimately to help the next person, as well as really meet the needs of that individual. But once meeting the immediate care needs of that individual is done, then the nursing role shifts to ensuring that somebody else can utilize that resource. So here we really see that kind of distributive lens of justice really playing out in how the emergency department was constructed. Second key finding is equity promoting practices as subversion. So nurses' talk illuminated that in many cases, equity promoting practices and nurses' work in promoting equity was not always institutionally supported through the discursive context of the emergency department and through the operating institutional processes and structures of the emergency department. Therefore, how nurses often enacted equity promoting practices was through subversion of those institutional processes and structures that did not foundationally, in many cases, support that equity work. And so nurses were in many instances finding almost workarounds to some of those institutional structures and processes in order to enact equity promoting practices, but really discursively framing this work as resistance to those structures and as subversion of those structures. And so as we can imagine, that was also often a very morally distressing and exhausting process on top of the kind of workload and the burnout in COVID and the drug toxicity crisis and many other intersecting crises, was to kind of be going through this process of often actively or sometimes almost subconsciously, but subverting the way that discourse kind of shaped how things were done and doing things a different way and finding creative solutions. And then in many cases, nurses were also able to seek some institutional support for individual action, and were looking for that institutional support for the individual subversive equity promoting practices that they were enacting. And sometimes that institutional support was found, and sometimes it was found, kind of felt that there could be more institutional support for some of those subversive practices. So we see here equity as subversion. This person is speaking about the triage process and acting in the triage role in the emergency department. And this quote I find really exemplifies how equity was not necessarily kind of discursively baked in to the institutional process, but how they were able to enact an equity lens and equity promoting practices as subversion of some of those institutional processes and structures. In this case, the triage process, which is, as we all know, a standardized process, but kind of shift that standardization toward equity aims. So they say, I've had cases where I think I'm going to give the bed, resource allocation, to that person with the overdose versus the person with the appendix, because yes, they need surgery and they're going to get care, but they're also sitting up fine in a chair and they can advocate for themselves and are safe. Whereas this person who came in with an overdose most likely hasn't been treated very well in their life, probably been fighting barriers all their life. And if we can lessen that, if we can honor their dignity a bit more, I feel like that's equity. And so here we see this, I think, wonderful quote that this individual is really thinking through this issue with equity discourses in mind and bringing in equity discourses as subversion to an institutional structure of triage that did not necessarily, in their experience, kind of inherently incorporate that discourse of equity, and indeed had maybe other kind of primary discourses at play, such as standardization and resource allocation and flow, but they were able to kind of subvert some of those structures and processes by bringing in equity discourses, which ultimately informed the equity promoting practice of allocating beds differently and of working through the kind of triage process differently. Here we also see equity as subversion in this kind of seeking of institutional processes and structures that could justify or kind of play into how equity promoting practices were taking up. So I really like how this quote kind of exemplifies that seeking out of discourse and seeking out of institutional supporting structures. So this is a complex story in which the primary nurse had gone on break, and this person who was part of the interview with me was covering, had been providing some patient care for an individual during that other nurse's break. And so the patient said, I'm taking some time out from the emergency department to use. And the original coworker who had gone on break was like, no, you can't. And I was like, oh, actually, I told him he could. And harm reduction is actually a hospital policy, so he can. She was obviously not very impressed with me at all. And she was like, well, if you're not back in 45 minutes, I'm giving up your bed to the patient. And he ended up taking an hour and a half, but she didn't give up his bed. I have to advocate for these people. Nobody else on our staff is going to. And so I have to say, in my own research, I didn't find that nobody else on staff was going to, but we can see here this thought of these equity promoting practices and equity discourses as being something that is kind of brought in often at an individual level by nurses, and that there might be some supports to be found within institutional structures, like the statement that harm reduction is actually a hospital policy, but also sometimes some difficulty in having those discourses potentially be dominant across emergency department healthcare providers or nurses, and having that kind of justification to really need to grasp onto to justify equity promoting practices. And so we're kind of enduring between this discursive context where we find that nurses' work is really kind of shaped in particular ways by dominant discourses in the emergency department, and then the taking up of equity promoting practices as subversion, we find ultimately there are these kind of pervasive power equity tensions in how the emergency department is set up and how nurses' work plays out in this kind of complex institutional context. And so I'm centering today on 3 of these core tensions, and I'll speak to each of them. But firstly, equity as optional and a matter of knowledge and awareness. So predominantly across institutional texts, nursing professional texts, and nurses' talk, equity was discursively positioned as optional, something that individuals could choose to take up and then to enact as equity promoting practices, but not something that was necessarily seen as core or mandatory or an inherent part of what nursing work in the emergency department looked like. And then as a matter of knowledge and awareness, more so than as a practice. So while nurses described many practices that they actually ultimately took up and equity promoting practices that they enacted in their practice, there was a kind of dominant discursive positioning of equity as being about having knowledge of inequities and maybe having some knowledge of equity itself, but mostly of inequities and having that awareness of inequities. But then there were limits to that, which I'll speak about in a minute. Also, initiatives with equity intentions ultimately upholding or sometimes reifying power structures. So there were some initiatives within that nurses were able to recount within the emergency department context that had equity intentions or kind of had intentions to advance some remediation of inequities or some kind of attention to some of these challenges, but ultimately in some key ways upheld certain power structures because they were situated in a context where dominant discourses were toward other things, and how the emergency department was constructed were toward aims of, for example, discharge or flow or resource allocation. And so it was very difficult then for some of these initiatives with equity intentions to kind of subvert those dominant discourses when those dominant discourses were ones that were really shaping how the day-to-day occurred. And of course, because those discourses were interconnected with power, with discursive power. And so individual equity initiatives were not always able to subvert those broader power structures, and therefore sometimes it kind of ended up re-perpetuating some of those power structures. And again, I have an example in a moment. And then ultimately, the emergency department setting being in tension between discursive power and equity. There were structures that really advanced these dominant discourses and this notion of discursive power. And then there were a lot of practices and meaningful initiatives that enacted and promoted equity. And so ultimately the space was kind of in tension, that there were these equity aims. And in fact, the emergency departments are doing a lot of work remediating inequities and addressing huge public health challenges and promoting equity, but that also discursive power shaped how care was provided. And so it kind of be seen as a space in tension. So firstly, when we think about equity as optional and a matter of knowledge and awareness, we can see here that there were a lot of ways in which this discourse was made visible and then kind of reinforced. So there were a lot of comments such as an educational initiative that was kind of meant to promote equity in a certain sphere, opening my eyes, which is a wonderful starting point, of course, to equity, but then a lot of comments that were accompanying that kind of talk were, I don't think it would have changed care, or I don't have any examples of how I've actually been able to play that out. So while a lot of educational initiatives and workplace structures were promoting knowledge and awareness of equity, that did not always translate into equity promoting practices or understanding what equity promoting practices might look like in this institutional context, or a lot of nurses not really being able to identify what that would look like as a practice. And then we can see some comments sort of illustrating the optional nature of a lot of equity initiatives. People stating things such as helpful if you want to, but it's not necessarily something I'm initiating, or you just do a lot of your own research. So I think that also really speaks back to how we see equity promoting practices being enacted as subversive action, and often individual subversive action, where individual nurses were kind of finding ways to take up these processes, but they weren't always positioned as something that was part of nursing work, an inherent part of nursing work in this institutional context. And then we see this just one example of some initiatives with equity intentions ultimately upholding power structures. So many nurses at both research sites spoke about familiar faces care planning and how this process had a lot of potential to remediate some inequities for those who make frequent visits to the emergency department, and ultimately to promote equity. And then there were some key ways in which this structure, as well as having some real benefits and having very positive intentions, ultimately perpetuating inequities within the emergency department, and not necessarily because of, lack of great intentions or lack of quote unquote success in other areas, but because this care planning structure was situated within broader forces of discursive power and broader structures in the emergency department setting. And so one individual told a story of someone who was frequently attending to the emergency department for an issue that I suppose could be described as maybe more personal care oriented, but was a gap in the community and sort of a greatly needed aspect of this individual's kind of healthcare suite of needs. And so this individual stated, we decided to trial refusing to do that kind of care for him when he presented, because obviously that's not emergent care. And so here we really see the discourse of emergency is for emergencies. And it felt drastic at the time. It felt like a mean thing to do, but it was actually really, really successful. And he stopped coming because his desires weren't being met. And so we can really see the discourse here of what success looks like, or how success can be constructed in some of these initiatives that have equity aims, but that maybe more dominant kind of discursive power forces are shaping than what success looks like ultimately in these initiatives. And so those broader discourses can ultimately kind of shift how equity initiatives might play out. But we can also see here some moral distress showing up about it feeling drastic and mean, and how some of that can really challenge nursing work and the work of other healthcare providers. And then lastly, as I spoke to, the emergency department setting in tension between discursive power and equity. And so the space just kind of being somewhere that maybe hasn't quite found its relationship fully to equity, while discursive power is also showing up as dominant. So this individual says, we're basically meeting the basic social determinants of health needs. So actually a little bit of a different discourse here from emergencies for emergencies. When you look at the broad system of healthcare, that's not what the emergency is intended to do. And here we more see it show up. But I often feel that emergency departments are like a little microcosm of society, and however things are going is the way it gets played out there. We're trying to fill some of those gaps of what the system isn't providing them. So there's a kind of question about almost what the mandate of the emergency department really is, and if the work that is currently happening is really the mandate, and maybe it should be or maybe it shouldn't be. But a lot of those kind of circulating questions and circulating discourses around what emergency quote unquote is and what it does. So some central takeaways that we have here from those key findings, and I also really look forward to your perspectives as well, are that there's value in emphasizing equity as a nursing practice. And this is really running in contrast to those findings of equity as optional, but also as a matter of knowledge and awareness. And while knowledge and awareness may be a key and central starting point to practice, that there's a need within our profession to emphasize equity as something that is done, and that shifting of inequities maybe cannot happen through knowledge and awareness alone. But if nurses are able to receive guidance and institutional support for enacting equity as a practice, then perhaps that is how we can shift some of these central inequities that are showing up in our emergency departments and across the healthcare system. And then alongside that, translating education, and we know there are a lot of very important equity promoting education opportunities and professional development opportunities and structures in our healthcare systems, but translating that to everyday nursing contexts. And I think part of that is to individual nursing contexts. We saw those quotes from participants around, it was really valuable, I learned a lot, but I don't know how it would translate into my practice here. And I think what's kind of behind that is a sense of, I don't know what an emergency department nurse would do from there. And so I think bridging that gap is something that we can really turn our attention to when we think about future research and interventions, and also as educators, kind of how we can help bring in that everyday nursing context to bridge the gap between knowledge and practice. We've also seen a lot of calls for strengthening mandates, policies, and their applications. And I think that there's even been some critique of kind of that approach, but we really see here how subversion was taken up as individual nursing action in many cases, and that there was real kind of power or empowerment in having policies and mandates to draw on as justification for some of those individual subversive action that was kind of happening. And alongside that, we have the potential to target some structures that have potential for promoting equity, but are maybe not currently able to kind of fully live up to that potential because perhaps of dominant kind of dominant discourses, constructing what the emergency department is or does. So one structure that I have my eye on, and you will have seen it in that prior quote, is the triage process. And that being, a standardized structure that leads to certain outcomes, but also has a lot of potential for promoting equity through that process, especially if we can think of it through some of these interesting kind of resource allocation lenses, and how equity can kind of be squared with resource allocation. And ultimately, triage is a structure that takes a standardized approach to resource allocation. So how can we add an equity lens into structures like that? But ultimately, while we can strengthen mandates, policies, while we can strengthen particular structures and initiatives, there's a call broadly also in the In Plain Sight document and in many other places, but this language is borrowed from In Plain Sight, is to hardwire equity into structures, into emergency department culture, because we see here that one of the challenges of individual equity initiatives can be that when they are in a broader institutional context that is shaped by discursive power, that it can be difficult for those individual equity initiatives to meet some of their equity promoting aims. And that if we're able to turn the lens kind of even further up in terms of how we hardwire equity truly into our structures and make equity a dominant discourse in particular healthcare settings, and ideally across the healthcare system, that ultimately can really be how we shape some of how nurses are able to enact equity promoting practices, not as subversion, but as a key part of their everyday nursing work. So I am so grateful to all of you for listening. I really hope that you will be able to share some of your comments or questions either in the chat, or if you want to say hello, and I'll close the screen here so that I can see all of your faces, if I remember how to do that. Okay.
Thanks, Allie. That was great, and a huge thanks out as well to the sites that supported this work and enabled it to move forward. And it's a great example of what happens when students and our settings that we work and collaborate with so well kind of come together to do this kind of thing. So huge shout out for that in particular.